Welcome guys and welcome to a medical lectures. Okay, so today is our topic about pheochromocytoma, and let's review it. What is a pheochromocytoma? So pheochromocytoma is a catecholamine secreting tumor typically located in the adrenal medulla. Okay, now let me tell you what does it mean. Actually, we do have kidney, right? We do have kidney, and over the kidney, what we have over the kidney, we have the suprarenal gland, which is also called adrenal gland. All right, now this adrenal gland do have three layers. Okay, this adrenal gland do have three layers. Let me tell you. Let's suppose this is adrenal gland and it have three layers. The outermost layer is zona glomerulosa, then zona fasciculata, okay, and then zona reticularis. Okay, zona reticularis. Okay, so zona reticularis. Now this pheochromocytoma is a tumor of zona reticularis. Okay, this pheochromocytoma is the tumor of zona reticularis. Now this zona reticularis tumor is secreting what? Secreting catecholamine. Okay, secreting catecholamine. Okay, secreting catecholamine. Now what are the catecholamine? Catecholamine are actually norepinephrine and epinephrine. Okay, so norepinephrine and epinephrine mean androgens are the catecholamines. All right, androgens are the catecholamines. Okay, so now androgens are the catecholamines. Now these androgens are doing what? These, we know that these are the sympathetic hormones, right? These are the sympathetic hormones. Now these are let's suppose this is our vessels, and they do have some receptor for the norepinephrine and epinephrine. All right, now what they do, this norepinephrine and epinephrine will come and act on these vessels, and it will constrict the vessels. All right, so it will constrict the vessels, and this constriction will increase our blood pressure. All right, now this increased blood pressure, this will call episodic type blood pressure. Why? I will tell you right now. Okay, so here you can see norepinephrine is acting on the vessels receptors and constricting the vessels and increasing the blood pressure. Now normally if we see our adrenal glands, right? Normally if we see our adrenal gland, so our adrenal gland, zona reticularis, normal physiology, it's secreting norepinephrine, epinephrine, but not that much. Okay, it is under the physiological. Okay, so it's secreting and giving some sympathetic activity, but not that much. But a pheochromocytoma is secreting too much norepinephrine and epinephrine, which is very dangerous. Okay, so now let's go back to the description, what they say. So a pheochromocytoma is a catecholamine secreting tumor typically located in adrenal medulla. Pheochromocytoma are usually benign 90% of cases. Okay, it is a benign tumor, but it is very dangerous, mean that it is constricting your vessels and give you episodic blood pressure, and this is a very dangerous type of. Okay, so for that reason, if it is a benign or malignant, we don't look for it, so we mostly do the other procedure. Let's check it out. Okay, so classical clinical features are due to excess sympathetic nervous system stimulation. Of course, epinephrine are the sympathetic hormones, so excess nervous system stimulation and involve episodic blood pressure. So right, because once the tumor give you too much pressure and secreting too much norepinephrine, so that time you will feel the blood pressure. That's why it is called episodic blood pressure. All right, now paroxysmal headache, okay, and diaphoresis mean excessive sweating will be there, right? Heart palpitation will be there. So why the heart palpitation? Because it is secreting norepinephrine and epinephrine, which are the sympathetic hormones, so it will act on your heart and give you the heart palpitation. And pallor will be there. Okay, and pheochromocytoma actually can be asymptomatic, but mostly it is present with the persistent hypertension. Elevated catecholamine metabolite in the plasma or urine confirm the diagnosis. All right, now let me tell you what does it mean. Actually we have some parameters, right? If our norepinephrine epinephrine level is exceeding to this level, okay, this midline. So let's suppose it is a blood level, okay, so it will appear in the blood. So this epinephrine will be in the blood, okay, it amount will be increasing in the blood. And if we see the blood test, so we can found the norepinephrine and epinephrine will be rise in the blood. Now let's see. Let's suppose this epinephrine is increasing too much and increase the renal threshold. Of course, this is the renal threshold, okay? It have a specific amount, specific value. If it increase this epinephrine and it cross the renal threshold, so it will appear in the urine. All right. Now it is appearing in the urine. So there is the confirmatory diagnosis of the Pheochromocytoma. Now let me tell you what does it mean. Actually, you know that, okay, so norepinephrine and epinephrine. Why we don't check? Actually, we don't check norepinephrine in the urine or in the blood. Actually, we check what? We check the norepinephrine and epinephrine metabolite in the blood or in the urine. Okay, so why we check the metabolite? Why we don't check the epinephrine directly? Because epinephrine and norepinephrine do have very short half-life. Okay, so because of the short half-life, it is going to metabolize into metabolite into what? It is metabolite into metanephrine. So we check the metanephrine in the in the urine or in the blood. But in the blood it is high sensitivity. Okay, in the blood it is high sensitivity, but in the urine it is high specificity. Why in the urine it is high specificity? Because you know that if it is crossed the renal threshold, so the amount is too much. The norepinephrine and epinephrine amount is too much, so that's why it is appearing in the urine. So now it is the high specificity. But in the blood, the amount is somehow can be increased by some other activity, so that's why it is not that much. It is sensitivity, but still the blood amount will be high. All right, now let me tell you. So while imaging, so what we have to do, we check the biochemistry positivity. Okay, if biochemistry level mean that the positive biochemistry mean that the norepinephrine and epinephrine is increasing in the blood and urine, and then what we do the CT scan, we do the MRI to localize the tumor. I hope you do understand. And the treatment is what? Surgical resection is the treatment. Okay, surgical resection is the treatment, and somehow we give the alpha blocker with phenoxybenzamine, with also the effective, okay, benefitive, effective. Now etiology mean the causes. Okay, so tumor arise from chromaffin cells which are derived from neural crest located on the location include 90% adrenal medulla physiological activity by the acetylcholine. Actually, this tumor arises from the chromaffin cells of the derived neural crest. Okay, so now 90% it is adrenal medulla tumor, but somehow it can also occur external medulla. Okay, extra medulla. So sympathetic ganglia will be victim, and 10% will be extra adrenal. Okay, and 10% multiple endocrine location mean that you know that the multiple endocrine neoplasia. So multiple endocrine neoplasia. All right, so multiple endocrine neoplasia, now it is a endocrine neoplasia, and many more endocrine diseases will be there. So with the many more endocrine diseases, the pheochromocytoma is also endocrine disease, right? It is an endocrine tumor, right? So this pheochromocytoma can include with the multiple endocrine neoplasia, can include with the new fibrochromatosis. Okay, and then von Hippel-Lindau disease. 10% rule mean that roughly 10% of pheochromocytoma are extra adrenal, multiple bilateral, mean that the both adrenal can be involved. Okay, malignant. Pediatric cases not associated with hypertension. All right, let's go to the laboratory test. Already you done with the diagnosis of pheochromocytoma. Congratulations. Anyway, laboratory test, whenever possible, all medication should put on hold 1 week prior to the testing. If you do the testing before testing, you have to give all the kind of the medication, means symptomatic medication for the other kind of symptoms like hypertension, diaphoresis, pallor. Okay, and best initial technique is what best initial test is a metanephrine in plasma, so it is a high sensitivity, already I told you. Okay, and confirmatory test is metanephrine, catecholamine, and 24-hour urine. Okay, so if we check like continuously 24-hour urine, anytime you check the urine you found the catecholamine, norepinephrine, epinephrine metabolite, metanephrine in the urine, so it is a high specificity, and it is giving you the confirmatory test of the pheochromocytoma. Genetic testing for the multiple endocrine neoplasia, two types A and B. Okay, and new fibromatosis 1 and von Hippel-Lindau disease. Okay, other diagnostic test is 24-hour ambulatory blood pressure monitoring. So what we have to check, we have to 24-hour monitor the blood pressure. All right, because this is the sympathetic neuron releasing tumor, so which will suppress our which will constrict our vessels to increase the blood pressure. All right, so adrenal abdominal CT scan, MRI after positive biochemistry. After positive biochemistry mean that like biochemistry level, we check the norepinephrine, epinephrine in our urine. So if that is positive, we found the norepinephrine, epinephrine in the urine. So after that we do the CT scan and MRI to localize the tumor. Other imagery to research for the potential additional scintigraphy. We do scintigraphy mean that we give some fluorescence chemical to the patient, and then we do the CT scan or MRI and X-ray. So under that we could find the easily and clear image of the pheochromocytoma. All right. So other imaging to searching for the potential additional tumor and patient with pheochromocytoma and MEN1 and MEN2, mean multiple endocrine neoplasia 1 and 2, new fibromatosis, new fibromatosis 1 and von Hippel disease. All right, so this you can see the histology of the pheochromocytoma, mean that look, the tumor is secreting too much norepinephrine and the cells are too much here. Okay, and these are the CT scan, image. So thank you so much for watching this video. I hope you got some idea, and we will have many more diagnostic cases like this in the future. Thank you so much.